Hi, my name is Dr. Wade Butod, and I'm a family physician and a hospitalist. As a hospitalist, I take care of many life-threatening illnesses, and many of the patients I care for are advanced in age or have some type of terminal illness. The purpose of this discussion is to address your situation and help you make difficult decisions during these difficult times. I normally sit down in my patient's room and I talk to them face to face. We discuss the specifics of their individual disease and their individual challenges. Because I can't sit in front of you and know all the details of your challenges, this discussion will approach things more generally. Ultimately, I want to help you to understand what your goals are and to give you options when things seem difficult. Even though I can't sit in front of you and talk to you face to face, I want to pretend that we are. I want to pretend that I'm your doctor and that you're my patient. I want to start off by apologizing because this is a hard discussion to hear. But please know that I'm having this conversation with you because I want to know and find out what really matters to you and what you really want. And then I'm going to fight for that with all that I know how and all of the modern medicine that is available. I'm also going to use very direct language because this makes it more clear. I want to empower you to make the best decisions for yourself. Please bear with me because I'm going to talk about some general things, and probably none of these things are a surprise or even new information for you. But I do believe that the way we talk about them here is going to be put into a different light than you've ever heard them. This line is the line of independence. If you're living above this line, then you are considered independent and don't need any outside help in order to thrive. If you're living below this line of independence, then obviously you are dependent. And without that help, then you could not survive. In actuality, things are a little bit more complicated than that. And in medicine, there are differing levels of independence. The most basic measures of independence are your activities of daily living, or ADLs. Your ADLs include dressing yourself, feeding yourself, being able to walk or transition out of bed to a wheelchair, being able to go to the bathroom by yourself, and being able to keep yourself clean or bathing yourself. Some slightly more complicated activities of independence include your instrumental activities of daily living. These include shopping for yourself, keeping your house clean, accounting both your money and your medications, being able to prepare your food, and finally, being able to use a telephone and navigate transportation, whether that's driving or taking buses. For the sake of this talk, these two lines are going to represent the ADLs, which is the dotted line, and the IADLs, which is the solid line. If you can do both ADLs and IADLs, then you are above both lines and you're considered independent. If you're unable to do IADLs nor ADLs, then you are below both lines. If you can perform your ADLs but not your IADLs, then you're between the dotted line and the solid line. And this is where we all start, a helpless little baby, completely dependent upon our parents in order to stay alive. We begin to grow up and learn how to do some things for ourselves. And this is probably where my little children are. They can, for the most part, dress themselves and feed themselves, but there are other things that they just can't do. So they would be in this area. We continue to grow up and eventually become fully independent. We're the highest above this line of independence at about the age of 25. Our brains are fully developed, our muscles are strong, and this is about the peak at which we'll reach in life. As everybody knows, it's all downhill after that. We begin to age and we begin to get medical problems and we get older and weaker, and life just happens. Whether it's bad luck or genetics or bad decisions, we all decline. If we are quote unquote lucky and we don't die from that car accident or get cancer at a young age, we'll eventually get so weak and debilitated that we start to struggle with our IADLs. And this is when we cross that solid line and go below that solid line, and we are now in a sort of semi-independent state. So at this point, when we can't perform our IADLs, then we usually need someone to help us. Maybe at first it's a kid or a brother or a sister who helps us with our shopping or helps us with our housework. And then you find that they start having to help you manage your medications and food preparation. If you don't have a family member to help with these IADLs, then typically these are the people who need to go into some type of assisted living. It's important to know that while you're in this state of semi-independence or assisted living, you are still able to perform your ADLs, where you dress yourself, feed yourself, can still walk and take yourself to the toilet and bathe yourself. Eventually, the natural stages of life and aging will cause you to lose even your abilities to perform your activities of daily living, and you drop below both of these lines. In the old days, this used to be extremely rare, but now with antibiotics and fluids and oxygen, many people reach this state of debility. Some individuals and patients are fortunate enough to have family members that can bring them into their home and provide all of the services to both dress them, feed them, help them walk, toilet, and bathe themselves, as well as all of the IADLs, such as shopping, housework, accounting, food prep, and transportation. However, some people don't have that ability. Those who have to rely on someone else to perform both ADLs and IADLs eventually end up in a skilled nursing facility, otherwise known as a nursing home. It's important to note that if you drop below these lines of independence and you don't have anyone to help assist you with these things, people eventually deteriorate and slowly decline and die. Ultimately, no matter what we do and what modern miracles of medicine and treatments and everything that we try to do, we all end up here and we all are going to die. And this is what our bodies are programmed to do. There's this time in life when things begin to get more difficult. You find yourself slowing down, taking more medications, going to more doctors, and basically you're needing more help from friends and family to keep going. This is what that vertical line represents when life begins to get difficult. This is the point at which your body is trying to fulfill the end of its program and die. Sometimes this happens quickly, but more often this happens slowly and painfully. This is the period of time that I call the end of life era. Let's talk about the differences between the time before the end of life era and the end of life era, because they have their own unique characteristics. Before the end of life era, when we're young and healthy, we have both all the time in the world and all the comfort and convenience we can ask for. As a young person, you might look forward and say, well, when am I going to die? And if you're 25 years old, that might be 60 to 70 years in the future. And to you, that seems like an eternity. You also wake up, can get out of bed and do anything you want that day. That is what it means to have both time and comfort and convenience. In contrast, in the end-of-life era, you cannot and typically don't have both time and comfort. In order to buy more time as life gets harder in this end-of-life era, you have to sacrifice comfort and convenience. You have to go to those doctor visits. You have to go to physical therapy. You have to ask your kids for help. And if you want to keep going, you have to make more and more sacrifices in order to buy more time. In other words, the harder your body tries to die, the harder you have to fight to stay alive. And that's a hard reality to face. Sometimes people have to sacrifice their independence in order to keep fighting for time. They have to sacrifice living in their own home or in their own hometown, and they have to go live in a nursing home close to their kids. But those are the sacrifices some people have to make to fight against the dying process. Here's another interesting feature of these different time periods in your life. When you're young and healthy and you're way high above this line of independence, you can have multiple things happen to you, such as you might fall and break your leg. You get a pneumonia, you can get a urinary tract infection. Heck, you can even get drunk if you want to, and you're still strong and healthy enough to be independent in your own home, taking care of yourself. That's what each of these little arrows represents. They are a threat to your health that takes you closer to needing someone to help you. When you're high above that line, you can suffer multiple insults to your health and still be fully independent. In the end of life era, things are different. It doesn't take much for someone who's barely living above that line, who's elderly, who's frail. They may have been perfectly healthy beforehand, but if you're over the age of 80, you are in the end of life era. It doesn't take much to put you in the hospital. It might just be a common cold or a little urinary tract infection. And all of a sudden, you're going from completely independent and living your life to all of a sudden ending up in the hospital with a life-threatening illness. People who find themselves with a sudden loss of independence or a change in their levels of independence usually have some small insult to their health. People usually call the ambulance at this point, or their family forces them to come into the emergency room. It's there they find out that they have one of these illnesses that are a threat to their life. If you're currently in the hospital, then you are below that line of independence. And without this hospitalization and medication or antibiotics or oxygen or therapy, you would die from this. It's also a fairly accurate generalization to say that you are in the end of life era. And that is sometimes a hard fact to accept. So that's the general overview of the cycle of life. Now, let's talk about goals. And in particular, let's talk about your goals. So before we talk about your goals, let's talk about, in general, what physicians are used to talking about. I'll tell you what doctors are used to talking about, and that is, how do we cure you? And this word cure, from my perspective, I don't like that word because everybody ends up dying. I like to use the word time. How do we buy you more time? And we physicians and medical students and nurses, and we're all used to training on how do we fix this, how do we cure that, and that's what all of our training largely focuses on. When a 30-year-old mother of 3 children comes in with a certain medical problem, we don't think about anything other than how do we fix this patient and get her back to her family. We only talk about how do we buy you more time. And of course that makes sense. We wouldn't offer this young mother any other option than how do we get you better. This kind of results in a difficult situation. Physicians are so good at talking about how we buy you more time. We are very terrible at taking care of people in the end of life era. Most of the time, we are stuck on our default, and that is, let's buy you more time. Let's do this procedure. Let's do that procedure. Let's send you out here. Let's send you there. Let's do this surgery. Doctors are good at talking about how do we buy more time. On the whole, doctors are not great at talking about what it's going to take to buy that time. We're not very good at talking about how much comfort you're going to have to sacrifice just to buy more time. Before you reach the end of life era, you get one option, and that is, how do you buy more time? But in the end of life era, you now have 2 options. You can choose to fight for time, knowing that you're going to have to sacrifice things in order to buy that time. But you can also choose to fight for comfort. So what does it mean to fight for time? It means you're willing to sacrifice comfort and convenience to buy more time. And this is very individual. Some people, even though they're suffering, they are really wanting to get to a certain event or to a certain birth or see their kid graduate from college or high school, and they're willing to do whatever it takes. And all you have to do is tell us, "Doctor, I want more time if it's possible." And we're going to be on your side 100%. Each time you have a crisis, another hospital visit, facing the need to go into a nursing home, you need to have dialysis, or you get a cancer diagnosis, you get to choose if you want to keep sacrificing your comfort and convenience to buy more time. What exactly does it mean to fight for comfort? Well, this is also a very individual decision. Some people are suffering significantly because their bodies are giving out on them. Maybe they have severe pain from cancer or severe arthritis and are unable to even get out of bed. Some people may be stuck in a wheelchair or having to live in a nursing home far away from their friends or family. All of these things might be considered suffering, and it's up to the person to determine if this suffering is worth the time that they're getting. For some people, however, that suffering is too immense. And just because we can keep them alive with other procedures and antibiotics and medications doesn't mean we should. I want you to know that you have the right in the end of life era to say, "I am done fighting for time." When someone's body is trying to die and we are fighting against that process, we're fighting against the natural course of things. When we're fighting against the death process and we are having to sacrifice our comfort to buy more time, we are essentially extending that time, but we're paying for it with immense suffering. When we choose to fight for comfort, we choose to discontinue life-prolonging treatments. If a physician can say that a patient has less than 6 months of life expectancy, then that patient will qualify for hospice. Hospice is a company of physicians, nurses, and aides whose purpose is to relieve suffering of pain and anxiety with different medications and treatments. Their goal is to keep people out of hospitals and in their own homes, surrounded by their family. And their goal is to help patients and their families during the death process. When you are ready to fight for comfort, you no longer have to wear that oxygen. You no longer have to spend nights in the hospital. You no longer have to go through chemotherapy. You no longer have to have your abdomen or lung drained of fluid buildup. You don't have to continue dialysis. And you don't even have to take your regular medications that are prolonging your life. You have the right to fight for comfort at any point in the end-of-life era. So right now, I want you to pause this video and read these questions. What is your goal? Is it to fight for more time, or are you ready to fight for comfort? What are you willing to go through to buy more time? What are you not willing to go through to buy more time? Please discuss your goals with your physician and your family, and they can help you to better reach your goals. You might be wondering, why do I share this with you? My goal is to help you maximize your quality of life. That's my goal as a doctor. If I don't ask you what your goals are, and all I do is tell you how to extend life, then I may simply be prolonging suffering and not helping you maximize your quality of life. I've seen so many instances where physicians and patients are stuck in the default decision of prolonging life no matter how much the suffering. As a physician for the past 15 years, I've helped many people survive life-threatening illnesses that would have killed them only 100 years ago. But I have also helped people that are suffering immensely to know how to fight for comfort using modern medical miracles such as hospice. I have helped people to understand what their goals really are so that they can share those with those that are caring for them. Many of my patients that I share this with often tell me that they've never heard this information put in this way before, and they often thank me for sharing with them. So why don't physicians talk about this more often? Or why aren't patients having these conversations more often? Well, the truth of it is there are a lot of challenges to hearing this discussion, to creating this discussion, and even being able to overcome our own thinking errors and guilt and family pressures to making the best decisions for ourselves. The first of these obstacles is the physician or nurse's own guilt and discomfort in setting up this conversation. We sometimes feel guilty or ashamed that we weren't able to fix our patient. We feel sad for the patient and feel like maybe we're missing something, or maybe we didn't do enough, before having a discussion about potentially fighting for comfort instead of fighting for time. A lot of times these conversations are taken in a very misconstrued manner, meaning the patient immediately jumps to the conclusion that the doctor is ready to just write them off and let them die. This is one of the main reasons I've developed this approach to this discussion, to make it easier for physicians and nurses and practitioners everywhere to be able to approach this discussion the same way every time with every patient, so that we can easily overcome our guilt and not have that discomfort in wondering how we should begin these kind of conversations. The second barrier is that sometimes patients and family members don't realize that the patient is living in the end-of-life era. They think they are still in the first era where they can have time and comfort, and that death is very far away. With a proper perspective, patients, family members, and even physicians who can understand where a patient is in this cycle of life can make decisions with this proper perspective. They can make informed decisions, knowing what they're going to get from certain treatments and what they can expect. Having an unrealistic perspective about where someone is in this cycle may sometimes lead patients and family members to seek after treatments that are going to offer very little in the way of buying more time and lead to a lot of suffering and pain. The third barrier that may prevent someone from being able to entertain all options of treatment is that sometimes people feel guilty that doing anything less than every procedure known to man is somehow giving up. I once had a patient who had end-stage heart failure, and he couldn't even walk across his living room without stopping to sit down. His life quality was very poor. Eventually, his kidneys failed, and he was put in the hospital and was told he needed to have dialysis in order to stay alive. I knew my patient very well, as I'd been treating him for years. And when I went into the hospital to talk to him, he seemed very hesitant to start up dialysis. He felt like his family was forcing him to do that. He also felt like if he didn't do dialysis, that it would be akin to committing suicide because he's not choosing to do dialysis. My patient was so tired, and his quality of life was so very poor, according to his own admission. He did not want to do dialysis. When I told him he could choose to fight for comfort instead of for time, he felt like that was the right option for him. In reality, because of his severe heart failure, he had been living on oxygen and been suffering for a very long time. He had been fighting for extra time for years with his heart failure. And 100 years ago, he would have died a long time ago. He'd already been fighting for such a long time to stay alive. I reassured him that he was no quitter and that he certainly was a fighter, and that was evident in how long he'd been going with all of the complex medical problems he'd had. The fourth challenge that people face in making end-of-life decisions is the guilt that is sometimes carried by family members of the patient. In many instances, the patient in the end-of-life era can no longer make decisions for themselves because of brain function decline like dementia. Sometimes family members know that their mother or father is suffering or they're living in a nursing home, but they feel so guilty for doing anything but keeping them alive. Even when they know that their parent would never want to live in this situation, the guilt that they carry can sometimes force them to keep their family member alive despite the patient's true wishes. I find it helpful to counsel family members to imagine that their mom or dad from 20 years ago could sit right down next to them and observe the current situation of mom or dad now. What would previous mom or dad say? Would they say, "Son, please keep me going even though I don't know what's going on"? Or would they say, "Son, it's time to let me go"? It's a very personal and individual decision. But ultimately, your parent loved you enough and trusted you enough to help make decisions for them, much like your parents did for you when you were a small infant. If we can let go of the guilt that we have surrounding this situation, it could help us better see the true goals that our family member would have. It would help us to make better decisions on whether we fight for more time or whether we fight for comfort. In the end, it's so much better when guilt isn't driving our decisions, but instead logic and knowing what our mom or dad or what we truly want deep inside. If you've made it this far, I'm pretty impressed. This is a long conversation. I know most of these are pretty generic descriptions and generic circumstances, but they're so common, and so many people have to face these decisions every day. I truly hope that this discussion has been helpful for you or for a family member that you know or someone that you're caring for. I would strongly encourage you to have these discussions with your loved ones and with those who are helping you make decisions. I encourage you to reach out to your doctor and talk to them about what your goals and wishes are. If you have no one else to talk to, please reach out to me at palliative.consulting@gmail.com. I can't promise that I'm going to respond to everyone or that I will respond quickly, but I truly wish I could have these discussions with anyone and everyone who is interested in hearing it.